A 26-year-old woman is brought to the emergency department because she feels lightheaded whenever she stands up. She has no significant past medical history. 5 months ago, she ended a relationship because she believed her boyfriend was eating excessively, and since then she has had a marked decrease in appetite with an associated weight loss of approximately 6 kilograms or 13 pounds. She has also missed her last 3 menstrual periods. She does not smoke, drink alcohol, or use illicit substances. Her family history is notable for coronary artery disease and congestive heart failure. On examination, her temperature is 36.6 degrees Celsius or 97.9 degrees Fahrenheit. While supine, her blood pressure is 102/68 millimeters mercury with a pulse of 86 per minute. Upon standing, her blood pressure decreases to 78/52 millimeters mercury, and her pulse increases to 122 per minute. Physical examination is notable only for dry skin and mucous membranes. Initial laboratory studies reveal a serum sodium level of 130 milliequivalents per liter, potassium of 2.9 milliequivalents per liter, and chloride of 90 milliequivalents per liter. Urine electrolyte analysis shows a sodium concentration of 65 milliequivalents per liter and a potassium concentration of 60 milliequivalents per liter. Which of the following is the most likely underlying etiology of this patient's symptoms? A. Cerebral salt wasting. B. Diuretic abuse. C. Laxative abuse. D. Low caloric intake. E. Mineralocorticoid deficiency. Or F. Self-induced vomiting. B. Diuretic abuse. This young woman presents with orthostatic hypotension, indicating intravascular volume depletion in the setting of abnormal serum and urine electrolytes. She has hyponatremia, hypokalemia, hypochloremia, and inappropriately elevated urinary sodium and potassium excretion. Together, these findings are most consistent with diuretic abuse. In patients with hypovolemia and hyponatremia, the kidneys normally respond by conserving sodium, resulting in a low urine sodium concentration. However, this patient has a markedly elevated urine sodium level, which indicates renal salt wasting rather than extrarenal losses. Conditions that cause renal salt wasting include diuretic use, cerebral salt wasting, and adrenal insufficiency. Additionally, hypochloremia normally leads to decreased urinary potassium excretion as a compensatory mechanism, but this patient continues to lose potassium in the urine, suggesting renal potassium wasting, which is characteristic of diuretic use. The presence of hypochloremia further supports ongoing diuresis, as diuretic-induced volume contraction commonly leads to contraction alkalosis. In this setting, urine chloride levels may vary depending on timing and type of diuretic. Importantly, surreptitious diuretic use is sometimes employed as a method of weight loss, particularly in young women with disordered eating behaviors, and these medications may be obtained from family members with legitimate prescriptions. Now, briefly reviewing the other answer choices. A. Cerebral salt wasting causes hypovolemia and hyponatremia with elevated urine sodium, but it occurs only in the setting of an acute neurological injury or neurosurgery, which is absent in this patient. C. Laxative abuse can lead to hypotension and volume depletion. However, sodium loss occurs via the gastrointestinal tract, so the kidneys conserve sodium, resulting in a low urine sodium. D. Low caloric intake may cause weight loss and some electrolyte abnormalities, but it does not explain the inappropriately elevated urinary sodium and potassium. E. Mineralocorticoid deficiency leads to renal sodium wasting, but is typically associated with hyperkalemia, not hypokalemia. F. Self-induced vomiting can cause hypovolemia, hypokalemia, and hyponatremia, but the kidneys respond by conserving sodium, leading to a low urine sodium concentration. Conclusion. Diuretic abuse causes increased renal excretion of water and electrolytes, leading to dehydration, weight loss, orthostatic hypotension, hyponatremia, and hypokalemia. In contrast to normal physiologic responses to volume depletion, both urinary sodium and potassium concentrations remain elevated, reflecting ongoing renal electrolyte loss. Thanks for studying with me. See you in the next video.